Move on to the next speaker. Dr. Jaishree is now with us. She is the second speaker. She was the second speaker. She has come now. You have uploaded here? Okay. Dr. Jaishree ka laga dijiyega, second wala. And she'll be speaking on diagnosis and management of dry eye premium IOLs, which is very, very important when you're implanting premium IOLs in these patients. Dr. Jaishree, please.
Thank you, Dr. Satyajit. Thank you, everyone. And thank you for including me in this IC. My topic is diagnosis and management of dry eye before the premium IOL implantation. The number of cataract surgeries has grown significantly in the recent years because increasing lifespan, more of elderly population, and that's why we need a clear and precise vision after surgery to improve the quality of life of the patients. Now, diverse kind of premium IOL are used, and so the accuracy of IOL calculation becomes very important. Dry eye disease is a very common disease affecting millions of population worldwide, and this is characterized mainly by the tear film instability, hyperosmolarity, and inflammation of the ocular surface. Dry eye disease in cataract surgery is important because the dry eye gets aggravated after the cataract surgery, and if you treat the dry eye before the surgery, it optimizes the result. And important is that variability in the corneal power IOL measurement, that also varies if there is a dry eye, and that leads to errors. So cataract surgery in recent years has evolved from vision restoration surgery to a refractive surgery. And to achieve good outcomes, it is very important to have a minimum post-operative refractive error. So a stable tear film is very important because this is for accuracy and reproducibility of the corneal keratometric measurements, and dry eye disease has a very deleterious effect. The importance of taking the patient's ocular history is also emphasized, and dry eye is often associated with other systemic conditions, medications. Patient is having allergy, having diabetes, glaucoma, using glaucoma medications, contact lens wearers. So we have to take a detailed history, and evaluation of the ocular surface before this cataract surgery is very important routine procedure to be incorporated in our practice. So the latest definition of dry eye is, it is a multifactorial disease of the ocular surface, and it is characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms in which the tear film instability is there, hyperosmolarity is there, and ocular surface damage and inflammation is there. Which now the dry eye you can broadly classify in the aqueous deficient and the evaporative type. The patient reporting to you may be asymptomatic or symptomatic with signs of surface disease, and then you can have aqueous deficient, evaporative, or mixed kind, and the management is to restore the hemostasis of the ocular surface. There are many risk factors, the more consistent among being the aging, female sex, mammalian gland disease, computer use, contact lens wear, pollution, some medications. So comprehensive detailed history should be taken, including symptoms, medication history, systemic conditions, and there are designed questionnaires, dry eye questionnaires, which help you to diagnose and grade the dry eye. And if patient allows and time is there, pre-op you can take, or just simple leading questions in the history. Then evaluation, the most important being the non-invasive tear film breakup time, osmolarity, and the ocular surface staining. So you can divide the dry eye into different categories depending on these factors. The important thing being the tear film breakup time, which should be over 10 seconds in normal, the tear meniscus size, the staining, and then additional things, lid, conjunctival folds, and Shermer's test, and other tests if time allows. And slit lamp examination, a detailed slit lamp just to evaluate the corneal surface luster, punctate epithelial erosions, meniscus size, the hyperemia of the conjunctiva, and mebominitis. So the most commonly we use is the tear film breakup time. The staining, using fluorescent stain and seeing the staining, how it looks under the cobalt blue filter, that gives you a aid in the diagnosis of the dry eye. The volume of the tear film, using the slit lamp beam, the lid parallel conjunctival folds, which should not be there, but if it is there, then depending on the number of folds, you have the grading. The inflammation, conjunctival, how much is conjunctival inflamed. The lid viper epithelium, the lid viper is the area of the upper and lower lid that wipes the tear film over the ocular surface, and you should carefully look at this area and see if there is inflammation and staining present. Mammography, blink analysis, this can be just seen while you are talking to the patient, taking the history. At least 10-15 blinks per minute should be there. Blepharitis, if it is present, that also can cause dry eye disease, and this is linked to the aqueous deficient dry eye. And then iatrogenic, due to some medications which the person may be using, some eye drops the patient may be using which has the preservatives like benzalkonium chloride, these can lead to the dry eye. And the systemic medications which often are responsible are NSAIDs like ibuprofen, many other drugs also, corticosteroids. Sherman's test to see the is a standard testing procedure, topography. And then coming to management, it is main at restoring the homeostasis using of artificial tears, educating the patient, modifying the environment, education regarding the any dietary modifications, and using the ocular lubricants and lid hygiene, warm compress. And if this is not adequate, then non-preserved ocular surface, the punctal occlusion, and if blepharitis is there, then topical antibiotic steroid or topical steroid, and anti-inflammatory like cyclosporin and liftigrast. I'll just take 1 minute more. So, osmoprotectants, trehalose, antioxidants, and preservative-free. Lid hygiene, very important. Lid scrubs, and anti-inflammatory, I already told, punctal plugs. And delaying, see, if the ocular surface is not stable, then we should delay the cataract surgery till it is stabilized. And in conclusion, I'd like to say, to ensure the optimal outcomes with premium IOLs, preoperative diagnosis and management of dry eye disease are crucial. This involves a thorough assessment including the patient history, slit lamp examination, and potentially tear film analysis, followed by tailored treatment to stabilize the ocular surface. Thank you.
Thank you so much, Dr. Jaishree. A wonderful presentation. Thank you so much.